Hello. Next, I'd like to speak to you about toxicology. There'll be several questions on the board exam about tox, and we all know that ingestions can be accidental or intentional. So, once someone is treated and survives their poisoning, please be sure to ask for psychiatric counseling and evaluation on those cases which are intentional. First, I'd like to talk about the general principles and initial evaluation of poisoning cases, of tox cases. And these principles can be used for any type of poisoning that you get. So you don't have to memorize each of these features for each individual substance. If you remember the overriding principles, the approach to the tox case will be much, much easier. Okay? So what are those principles? Of course, like everything else, airway, breathing, circulation are the most important principles of emergency medicines. Then the next thing you're going to do is you're going to find out what the medication they took is, or the poison they took is. And one of the ways you're going to do this is you're going to ask the patient. If there are paramedics available to ask, you'll ask them. If there are police available to send to the house to look for pill bottles, you'll do that. If the patient's wearing a medical alert tag, you'll look at the medical alert tag. It'll give you some idea of what types of pills the patient has. You'll interview family members. You'll take whatever help you can get. There's an option on the test to say, I want to speak to somebody about what happened today. That's always a good thing to do. After we get the history, we're going to look at what's called the toxidrome. And the toxidrome is the constellation of symptoms and physical exam findings that the patient has. And different poisonings have characteristic patterns. In other words, we're going to have a really good suspicion about what the patient ingested long before we get the drug screen back. We're going to have a good idea what the problem is before the blood tests come back to confirm our suspicion. Okay? We're not going to wait for the blood test to tell us what the poison is before we begin our treatment. We're going to begin our treatment based on the general principles and our assessment of what the most likely substances are based on the history and the toxidrome that the patient presents with. Okay? Of course, the top priority is to prevent any more poisoning from getting into the patient. We want to prevent absorption. All right? So how do we prevent absorption? We either empty the stomach or we give the patient activated charcoal. What charcoal does, the patient takes the charcoal by mouth, PO, can drink it, and it binds to the toxin and prevents the toxin from getting into the bloodstream. And quite simply, the bound toxin to the charcoal is eliminated in the stool to prevent absorption. Okay? For that amount of poison or drug that has gotten into the bloodstream, we want to do what we can to speed elimination. That's the next step. So there's just a few specific poisons that we could do, a few specific things we'll discuss. After that, I ask myself, are there any antidotes that would work for this particular ingestion or poisoning? And there really aren't that many to remember, actually. Okay? And that brings us back to airway, breathing, circulation, or supportive care again. The main thing to do for the poisoning oftentimes is supportive care, airway, breathing, circulation, maintaining proper acid-base balance, and let the body eliminate the poison itself is commonly all that's needed. So let's look at these in a little more detail. The resources to find out the history. Medical alert tags, interview the patient, interview the friends of the patient, whoever brought the patient to the hospital, interview the police and the medics. Okay? All right? We're not going to wait for the drug screen. This is the key point. If there's a choice of one, wait for the drug screen, or B, treat the patient, the answer is always B, treat the patient on poisoning. You make your best guess and you treat. Let's go over next a generic case of I took pills. All right? Here's a 28-year-old who ingested a bottle of pills, let's say 30 minutes ago prior to presentation. Okay? The patient comes in, says, I took pills, but won't tell you the name of the pills, or doesn't know the name of the pills. What do you do? Okay? Well, I do my ABCs. The patient's talking. That's fine. I ask him about the pills. I send the family back to look for the pills. That's fine. Next, I try to identify the toxidrome. And I look at the physical findings that'll give me a hint as to what the ingestion could be. Okay? So what causes meiosis? Little pupils. What causes meiosis? Okay, is it clonidine? Yes. Barbiturates? Yes. Opiates are the classic. How about cholinergic poisoning? Yeah. And there's other things that cause tiny pupils, like a stroke, like a Pontine stroke specifically. Okay. All right. If he came in with very wide pupils, I would suspect that the patient had anticholinergic poisoning or perhaps took a sympathomimetic. What's a sympathomimetic? A sympathomimetic is amphetamine and cocaine, those type of drugs. Okay? What causes dry skin? No sweat in the axilla. That would be another case of anticholinergic poisoning. Okay? Wet skin diaphoresis. What do you see that in? You see that with cholinergic poisoning as well as sympathomimetics. Okay? So when you combine these physical findings together, you could start to take a guess at what it is. All right? Okay? For example, both sympathomimetics and anticholinergics cause tachycardia. Both sympathomimetics and anticholinergics cause mydriasis, wide pupils. But if you look at the skin, you can separate them out on the physical exam. Anticholinergic poisoning, they're dry. There's no sweating. Amphetamine overdose, cocaine overdose, they're diaphoretic. So based on this, you surmise what the patient took. All right. Now and then you'll get someone that has an overdose that has blisters, and you're going to think about barbiturates and carbon monoxide poisoning in that case as well. Here you go. Here's some toxidromes. Which toxidrome is this? You tell me. 69-year-old man has chronic low back pain, and he's found, and they'll give you some indication that he's a decreased mental status. He's slow, he's stuporous, he's confused, he's sleepy, he's somnolent, he's comatose, he's unresponsive. They're going to tell you something like that. They're going to talk about respiratory depression, respiratory rate of 8 here, tiny pupils, right? Hypotension, pinpoint pupils, you know. And then they'll give you some other mark to indicate that this is an opiate, right? There's a needle in the arm, or maybe they'll give you a cancer patient who's covered with fentanyl patches. Fentanyl for pain, opiates, right? So you're going to know that this is narcotics. This is opiates, long before you get a drug screen back. Okay? Opiates cause a decrease in heart rate, respiratory rate, blood pressure. They're sleepy, CNS depression with meiosis. All right? Yes, clonidine can look the same. What toxidrome is this? A 27-year-old medical student that's acting crazy and violent. Okay? Tachycardic, hypertensive, dilated pupils, and diaphoretic. Okay, that might be one presentation of this toxidrome. Another might be a 30-year-old man who's agitated, has angina, and comes in from a party, says he was partying. He might also present with a severe headache or stroke due to his severe hypertension. Lastly, this case might present with a 16-year-old who is screaming mad, out of control, wild, takes every security guard in the hospital to hold down on the bed. What toxidrome is this? Sympathomimetics. Okay? This is the amphetamine, cocaine, or PCP. Right? The first case is what? It's amphetamine. Patient's trying to stay awake to study for his tests. The second case is what? This is cocaine. And cocaine can cause acute MI, it can cause acute hypertensive encephalopathy, it could cause acute cerebral hemorrhage. case number 2. Case number 3, the 16-year-old PCP, angel dust or animal tranquilizer, is also considered a pathomimetic. Okay, so in these people, all the vital signs are up. Blood pressure, heart rate up, respiratory rate up, temperature up. The wide eyes, agitated, no CNS depression, they're agitated, and they're sweaty. Okay. Okay, how about this case? What toxidrome is this? This case will be presented a couple different ways. The traditional way is it's a farmer who's dusting his crops, and they get organophosphate poisoning, because that's what he's putting on his field. The second way they'll give you this case is it's someone who's depressed over breaking up with his girlfriend, and he drank a bottle of insecticide, organophosphate poisoning again. And the last way they're going to give you this case, it's going to be a mass casualty bioterrorism situation where there's thousands of people in the subway, all who are symptomatic from someone releasing organophosphates in the subway. And what are the symptoms? There's salivation, urination, defecation, lacrimation. Salivation, urination, defecation, lacrimation. You can make it a little song if it helps you remember. These people are not that pleasant to be around, as if you can imagine. Okay? They have bronchorrhea and have bronchospasm, so they might be wheezing. And their heart rate is very slow. They are bradycardic. Okay? If I tell you in addition they smell like bug spray, or they smell kind of like that garlicky smell of bug spray, then you're going to know that this is the cholinergic poisoning toxidrome. Okay? Okay? All right, so, there's different mnemonic devices to remember the symptoms. If you like this one, salivation, lacrimation, urination, defecation, they have vomiting and diarrhea. They have bronchorrhea, they're crampy. They have small pupils. Okay? Those are all the muscarinic symptoms. And the nicotinic symptoms that ultimately kill the patient is they have some fasciculations of their muscles, and then there's such muscular weakness they're not able to breathe. The diaphragm doesn't move, and they die of respiratory depression at the end. All right. Pathophysiology. Ugh. Acetylcholine is broken down by cholinesterase, right? What the organophosphates, what this poison does is it inhibits the cholinesterase enzyme, right? That's the problem. So acetylcholine, too much builds up at the synapse, right? If you don't treat this in a timely fashion, the cholinesterase enzyme is irreversibly damaged by phosphorylation, and then the patient could remain weak for weeks, weak for a very long time, many, many days, until new cholinesterase enzyme is produced by the body. So the treatment for this, the first step, what's the best first step? Well, the best first step for cholinergic poisoning is actually be safe. Don't get yourself intoxicated, because this stuff is often absorbed by the skin. So if you're a healthcare worker, the first step is to put on protective gear and clothing and not be a victim yourself. The second step is to do ABCs and wash the patient off. But the next first best medicine to give is atropine. Atropine will speed up the heart rate and relieve the severe bradycardia. So actually, by giving atropine until the heart rate's up to 100, you can help reverse the symptoms of the cholinergic poisoning. Okay? Then the next drug you want to give that same morning, the same time the patient comes in, is the 2-PAM, also known as pralodixine. Okay? And if given in time, this prevents the irreversible damage to the cholinesterase molecule. Okay? So the drugs to remember for this is atropine and 2-PAM. There is a blood test you can do for cholinergic poisoning to prove your diagnosis. That's the red blood cell cholinesterase level or the plasma cholinesterase level. These take weeks to come back, a week to come back from the lab. So these can be ordered at the time of initial presentation, but treatment should never be delayed waiting for these reports. Okay? Treat first, prove later. Emergency medicine. What toxidrome is this? Here's another one. 20-year-old took a bottle of Benadryl, diphenhydramine. or it'll be tricyclic overdose, amitriptyline. Or it could be some Parkinson's medicines like Cogentin. Or they can give you a teenager that ate some Jimson weed. Okay? All these people will be dilated pupils, blind as a bat, altered mental status, agitated, mad as a hatter, mad as a goat. Okay? They will all be dry as a bone, have decreased sweat production. Okay? And they'll all be hot, hot as a hair. Okay? If you have someone walking around naked in public and they seem agitated, it's probably anticholinergic poisoning. These people like to take their clothes off because they're hot and dry. All right? So any of these things would be anticholinergic poisoning, anticholinergic toxidrome. Oh, there it is. Hot as a hair, dry as a bone, mad as a hatter, red as a beet, blind as a bat. They also look flushed. What are the vital signs? They're tachycardic. They have wide pupils. Okay? And it's the opposite of cholinergic poisoning, so they don't have frequent urination, they have urinary retention. They don't have diarrhea, they have constipation. It's the opposite of cholinergic. Okay, let's take the next toxidrome. 45-year-old woman being treated for anxiety, and she took a bottle of her sleeping pills. She says she just wants to sleep. Or it might be someone using benzodiazepine for recreational purposes. Benzodiazepines, you think of Sleeping Beauty. Vital signs are pretty much normal. They might be slightly depressed. There's CNS depression. They look like they're sleeping. Okay? That's benzodiazepine toxidrome. What causes hallucinations? You get someone in who's hallucinating. The first most common thing I think of actually is alcohol withdrawal, especially if they're tachycardic and febrile and hypertense. Anticholinergic poisoning can cause hallucinations, as well as the typical things we think of for hallucinations like LSD, right? PCP. You can hallucinate by going into the spice cabinet and taking out all the nutmeg. Don't forget that other medical conditions, anything with high fever, can make you delirious and hallucinate, including encephalitis. Okay, now, so we figured out the toxidrome, and we want to do everything we can to prevent absorption, right? So the first thing you think about is, well, let's empty the stomach. Hey, that way it won't get absorbed. Great idea. So how are we going to empty the stomach? Syrup of Ipecac is for home use now. Syrup of Ipecac, you drink the stuff, and 15, 20 minutes later you vomit, right? The problem with syrup of Ipecac for hospital use is that its mechanism of action, the vomiting, is somewhat unreliable. Some people don't vomit at all. Some people you can't get them to stop vomiting. And when they vomit, they only empty about 1/3 of their stomach anyway. 2/3 of the pills remain in place. So Ipecac's for home use. Once you're in the hospital, if you need your stomach emptied, the way you do it is gastric lavage. Okay? Gastric lavage. Now, you can't use a little NG tube. Why? Because the NG tube has these little bitty holes in the tip of it, and the big pill fragments won't go through into the tube. So you need what's called an EWAL tube, or an oral gastric hose. And that's an accurate description if you've ever seen one of these. It's about the size of your thumb. Oral gastric. So you get the idea of what the problems are. You can cause a lot of bleeding or trauma. Patients are going to gag and vomit up around the outside of the hose and possibly aspirate. You got an idea of what the problems are. But the good thing about the oral gastric hose is you can suck out a lot of pills out of the stomach very, very easily. Okay? So, does everyone get oral gastric lavage? The answer is no. One thing that I'm concerned about is the time of presentation. If the patient comes the day after they took the pills, I don't do oral gastric lavage because there's no pills left in the stomach anyway. In fact, at 1 hour, only about 50% of the pills remain in the stomach, 1 hour after ingestion. And at 2 hours, only 15% of the pills the person ingested remains in the stomach. So, after 2 hours, I'm only going to get 15% back. Is it worth the risk of the procedure? That's what you have to ask yourself. So in general, after 2 hours, people are not getting oral gastric lavage. Okay? All right? What else are contraindications to gastric lavage? If someone is decreased mental status, I don't do oral gastric lavage without intubating the patient first. If someone has decreased mental status, I must protect their airway with that cuffed endotracheal tube prior to doing the gastric lavage, because they are going to puke and retch, and stuff's going to come up around the outside of the tube as well. Okay? So if they tell you the patient's stuporous or comatose or change in mental status, and they come in within 2 hours of an ingestion, and it sounds like it's something dangerous, it's not that they took 3 amoxicillin tablets or something dangerous, I'm going to do oral gastric lavage after intubation. When else do I not do oral gastric lavage? Well, I don't do oral gastric lavage if the patient ingested or drank an acid or a base. If the patient has a burnt esophagus, I don't really want to take this hard, rigid tube and push it up against that friable, damaged esophagus. You might end up with a tube in the mediastinum. Never a good thing. Okay? The other thing I don't do oral gastric lavage is, I don't do gastric emptying, I should say, is for hydrocarbons. Okay? If someone drinks kerosene or gasoline, you don't empty the stomach then either. So no stomach emptying by any technique for acid or base, no NG tube, no oral gastric hose. If it's a hydrocarbon ingestion, I'm talking about gasoline, kerosene, lighter fluid, no gastric emptying by any means, because if you bring up hydrocarbons, this stuff has a tendency to just flow up over the epiglottis and down into the lungs and cause aspiration. So no stomach emptying for hydrocarbons as well. So the most important step for preventing absorption, I'm going to tell you, is the charcoal. Most patients get charcoal. It's by mouth, stir it up, they can drink it. If you happen to have an oral gastric hose down, you can push it down the oral gastric hose, but the patient can drink it just as well. All right? When the charcoal's in, what tests are you going to get? Well, get a urine sample for the pH, get urine and serum tox screen. I get an aspirin level, Tylenol level, drug screen, that's fine. Get all your routine chemistries and electrolytes, that's fine. And many of these ingestions need to stay in the hospital and have psychiatric evaluation. What does the charcoal do? The charcoal binds the poison before it gets into the bloodstream. Okay? Is there any reason not to give charcoal? All right, well, it doesn't work for certain things. If I know the patient just took iron, heavy metal, I wouldn't use charcoal. If I know they just drank kerosene, hydrocarbon, I wouldn't use charcoal because it doesn't bind to the charcoal. If it's a mixed ingestion, iron and Tylenol, for example, then I would certainly give the charcoal to bind up the Tylenol. Okay? The other reason I don't give charcoal is if there's an acid or alkaline burn. Number one, it doesn't neutralize or bind the acid or alkali. And number two, the charcoal is very black and gritty, and it's going to stick to the burnt inside skin of the esophagus, making endoscopy very hard to interpret when the gastroenterologist comes to look at the patient's esophagus. Okay. Charcoal comes in 2 formulations, with sorbitol and without. The sorbitol is a cathartic that helps speed the charcoal along, as this stuff can be very constipating. Okay. If someone has an anticholinergic poisoning, I could give repeated doses of charcoal, a couple hours apart. Why? Because of the anticholinergic poisoning, the gut is slowed down, and there's more time for the charcoal to bind with the poison before it's absorbed. What's the downside to charcoal? Not much. I wouldn't give it to someone who's obtunded that has to have a good airway, because I don't want them to aspirate drinking the charcoal. That's really it. What's polyethylene glycol? Trade name Go Lightly. This is the stuff you take when you're having a colonoscopy, and it's a prep. You drink this solution, and within an hour, the Go Lightly is coming out the other end. It flushes the colon, the whole intestinal tract, clean of any pills or fecal matter, anything that's in there. Okay? So we prevent absorption by doing whole bowel irrigation when there are pills beyond the stomach, and it's a material that we know is not absorbed rapidly. So for example, if someone drank a quart of ethanol or methanol, we're not going to give polyethylene glycol because we know this stuff is already absorbed. Things that aren't absorbed rapidly are like packets. People that are smuggling drugs wrapped in condoms, that's not absorbed. Things that are, say, sustained release preparations or enteric-coated preparations, those type of pills break down and are absorbed slowly and might benefit from polyethylene glycol and flushing them out the rectum. Metals, lithium, iron. If someone takes, I don't know why you eat lead, but if someone had a lead ingestion, you would be able to use polyethylene glycol to flush this material out the other end before it's absorbed by the body. This is really interesting because the things on this list that whole bowel irrigation might be useful for are also things that show up on X-ray. So if you take a KUB or a plain film of the abdomen and you see the pill fragments, it's most likely to be heavy metal, the lead, lithium, iron, the drug smuggler with rubber packets of drugs, enteric-coated pills, sustained release pills, and chloral hydrates on this list. CHIPES is the mnemonic. So if you take an X-ray and see the pills on the X-ray, go ahead and give polyethylene glycol to prevent absorption. A few things you can aid elimination with alkaline forced diuresis. And the two things that you can aid elimination for with forced diuresis are aspirin and phenobarbital. That's it. Okay, so how do you order this? You have to give the patient bicarbonate. You have to give an amp of bicarb and a liter of D5 in water. For aspirin, you want to get the pH above, urinary pH that is, urinary pH above 7.5. All right? How else could you speed elimination from the body? You can speed elimination from the body by dialysis. But you know what? There's scant few things that are dialyzable. The classics are aspirin toxicity. If you're very ill, call for dialysis. Lithium toxicity. If you're very ill, call for dialysis. Also, the toxic alcohols of methanol and ethylene glycol. For patients that are severely acidotic and ill, dialysis is one of your correct answers. That's really it. Most other poisons you don't dialyze. Okay? You could use hemoperfusion with a couple things like dilantin, phenobarb, and Tegretol, carbamazepine. But everything else, you cannot use this technique. Lastly, the antidotes, there's just a few. There's not many antidotes. One thing to remember is your coma cocktail of glucose, Narcan, thiamine. Repeat after me. Glucose, Narcan, thiamine. Sing a little song, okay? Glucose, Narcan, thiamine are good things to think of at anyone that has a change in your mental status. You have a change in mental status, you want to either give D50 or check a drop of blood at the bedside and measure their sugar. Okay? You don't want to leave someone hypoglycemic for hours and hours. Okay? Narcan reverses opiates. And thiamine is traditional to give as well, or Wernicke's. Okay? Putting someone into acute narcotic withdrawal with Narcan is not dangerous. Patient doesn't like it. They may feel every ache and pain in their body, which they haven't felt in a long time because it's been covered up by narcotics, but it's not life-threatening. Okay? We do not give Mazicon or flumazenil for benzodiazepine overdose. Why? The answer is that Mazicon or flumazenil, in the setting of someone who is benzodiazepine dependent, will cause status epilepticus. So they'll start seizing and they won't be able to stop. Okay? So we do not give flumazenil. What you do for benzodiazepine overdose is you do airway breathing circulation, you identify the toxidrome, you give charcoal if appropriate, right? And you do supportive care of their airway breathing and circulation, and you wait for the body to metabolize the benzodiazepine on their own. Okay? We're going to talk a little bit about toxic alcohols. That means methanol and ethylene glycol. And for those two poisons, one of the antidotes we give is ethanol, the active ingredient of whiskey or beer. And the reason we do that is that the ethanol prevents the methanol and ethylene glycol from being broken down into more toxic products. We'll talk about that in some detail. Another antidote is Mucomyst for Tylenol poisoning. Okay? Mucomyst is also known as NAC or NAC. You might see it written out as N-acetylcysteine. So if the patient's taking Tylenol, also known as acetaminophen, the answer for antidote is going to be NAC, Mucomyst. Okay? And lastly, we already talked about organophosphates. That's atropine and 2-PAM. Okay, well, that's the end of the general principles for toxicology. And if you keep those in mind, you'll always be on track with the tox case. Next, we'll go over some specific poisonings.